these are other extractable antibodies that you can get that helps predictability. Some are probably actually causative. It doesn't really matter because you can't do anything about them. But let's go down through these. Anti-SCO70, if it's positive and you can correlate it with the patient's symptoms, scleroderma. If you have scleroderma, if you have beginning symptoms of scleroderma, is that a Snuggie you have on?
Yes, sir.
So if you have symptoms of so I want you to know that for I think it was 10th anniversary, I got my wife a Snuggie. You know, that wasn't the only thing, but that
10th anniversary.
and I had to call health for the 10 years since. So if you don't mind, I'm going to share your picture with my wife and say, look, she got this for her 10th anniversary. So there you go.
She's been married for 10 years.
The Snuggie and the Squatty Potty. You know what? They use the hell out of that Squatty Potty. They made fun of me about that. So anyway, did I finish talking about it? If you suspect scleroderma, Crest syndrome, or progressive systemic sclerosis, the SCL70 will be positive. The other one that's very specific is anti-Smith antibodies for lupus and anti-double-stranded DNA for specific for lupus. So you have to put these together. If Miss Ado comes in with a rash, a facial rash, she's got positive anti-double-stranded DNA, anti-positive anti-Smith. She has a high ANA. She's got a negative rheumatoid factor. That ANA has a nuclear pattern. That's pretty doggone good evidence that you have lupus. Problem when you're dealing with a lot of these rheumatoid diseases is some of them are positive, some of them are negative. If she had an anti-nuclear pattern here, for 1 to 1,280 ANA, negative RF, negative Smith, negative anti-double-stranded DNA, she got a facial rash. Does she have lupus? Are you going to call it lupus? You could get a biopsy of her skin. They'll tell you, the dermatopathologist will tell you whether or not the skin shows evidence of lupus. So that's the problem with these rheumatoid diseases, that you don't get textbook results all the time. And you have to, if you're going to get these extractable antigens, you better know where am I going with this? You better know what you're going to do with this data. Do you have enough evidence to start treating her with Plaquenil and then refer her to a rheumatologist 3 months from now? Are you going to try to take care of her? Are you going to try to prevent the progression of her disease, or are you going to let the rheumatologist do that? There are a lot of difficult decisions in connective tissue diseases. Okay? Anti-single-stranded DNA, never get that. It's not specific to anything. Anti-Rho and LA are associated with lupus and Sjogren's. They're associated with it. Unlike anti-SCO70 or anti-Smith, there's no causation that can be identified. So that's the difference in the wording here between associated and specific. Now let's look at the specific diseases. Psoriatic arthritis. This is the guy yesterday I was talking about on methotrexate. Did I just mention him? What did I say? What was I talking about with him? The biologics, the 28,000, yeah. He has psoriatic, his nails look just like that. He's an employee here on campus. He has psoriasis. It's not really that bad now. It's controlled on methotrexate. Latassic went over methotrexate as a DMARD, right? What you get with psoriatic arthritis is an elevated SED rate. Rheumatoid factor doesn't correlate with psoriatic arthritis. And there's really nothing else that does either. It's based on, if you got a biopsy of the skin, it would certainly tell you. It's based on a clinical observation, or a clinical judgment. You can treat this, you can refer them to dermatology, you can refer them to rheumatology. Lupus, little explanation for lupus up there on who gets it. Mostly females, mostly young females. Teenagers to in their 20s, very high incidence there. It's not so much the, and I was telling JC this at the break, it's not so much the arthritic symptoms related to lupus, and there are a lot of arthritic symptoms, not so much the rash. It's when the inflammatory process starts involving these linings, specifically the pericardial sac. You can develop a restrictive pericarditis, which is functionally like tamponade. You can have a thickening of the pleura of the lungs that alters breathing. It also involves the peritoneal lining as well, that produces these vague abdominal complaints that you can't put your finger on. But the problem with vague abdominal complaints, particularly in a reproductive age woman, is there are a lot of things that are bad. If a person comes in with these vague abdominal complaints with lupus, with a diagnosis of lupus in her history, is it just a peritonitis related to lupus, which you just put them on a steroid and the NSAID and it goes, it's all better? Or are you going to miss that appendicitis or God knows what else women get? I mean, the list is huge. This is easy. These things can kill you. Okay? Here we go with the different testing. The ANA, as I mentioned before, is going to be positive. Titer is going to be positive. You're going to have a pattern that's not homogeneous. You're going to have a specific pattern associated with it. The CDC is usually low because of a disease, anemia of chronic disease. The urinalysis, the reason you want to get the urinalysis is to look for kidney damage due to the disease. You're not going to see this early. This is going to be something you're going to encounter in progressive disease. The acute phase reactants will typically be positive, mostly all the time. Remember, ESR and C-reactive protein are called acute phase reactants. And as far as the extractable antigens, as I mentioned on the earlier slide, Smith and double-stranded DNA. You know, if you want to sit there, when you are studying for this, if you want to sit there and make a table, because you're going to have to interpret these studies on the exam. You know, is it lupus? So you're looking for positive here, 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 and how they present. And this is how they present. This is the butterfly rash. When you hear the word malar, M-A-L-A-R, or butterfly rash in a young female, the answer somewhere is going to be lupus. Or if I ask you what is the most likely positive extractable nuclear antigen in a patient presenting this way, you would say anti-Smith or anti-double-stranded DNA. Sjogren's disease is, by the way, lupus and Sjogren's are very common disorders. If you haven't encountered, who's encountered them at Good Shepherd already? You haven't, there are tons of patients over there with these diseases. Okay, Sjogren's disease is an odd duck. It mostly involves things that secrete. And if you look at here, the lacrimal glands and the salivary glands, somewhere you go, they dry mouth and dry eyes. That's one of the biggest problems with people with Sjogren's disease, at least early on. Later in the disease, they can have more significant things like interstitial pulmonary fibrosis. The mortality of interstitial pulmonary fibrosis is almost 100% at 1 year after the diagnosis is made. It's a nasty disorder. And it's an inflammatory disorder, just like the other ones we're going to talk about. The CBC will help confirm but not diagnose anything. Positive ANA, RF, and Rowe and Law. Not causative, but predictive. Unfortunately. So when you get this Reichland profile back, and you've got a positive ANA and a negative rheumatoid, negative Rowe and Law, you got a person presenting, the chief complaint is dry mouth. Are you going to call it Sjogren's then? So, it's a tough decision. That's why, when it comes to these testing, these different antibodies, I kind of limit myself because it's for two reasons. One is they're hard to interpret because you usually don't have a textbook where everything's positive or everything's negative. And the second thing is the treatment. I don't want to go beyond methotrexate or Plaquenil. I would prefer a rheumatologist tell me put them on Plaquenil or keep them on Plaquenil. And I don't prescribe biologics. And I mentioned that to you last week, I think. Ankylosing spondylitis, one of the speakers has commented on. Oh, by the way, a couple of points regarding speakers. Ron told me it was Flynn, not Travis, who said about the glue in the Pseudomonas. So we won't hassle Travis this afternoon about that. The other thing had to do with open fractures always go to surgery. Somebody said except, I think Brad said except fingers and toes. What he was talking about was if a farmer comes in and he's cut his finger off in a farming accident, they don't go to surgery. It's an open fracture, right? If he's cut his finger off right here, it's an open fracture. There's bone. You can tap bone. All you do to those, if you're not going to put the finger back on, is bandage it and let it heal. That doesn't go to surgery. So that's what they were talking about. Any fracture of a long bone or anything you're gonna save has to go to surgery. But most of the time, in the ER, you're gonna see it all the time. People are losing the tips of their fingers. They cut off, their distal failing, half of the distal. You don't send those to surgery. You just make sure they don't get infected, you cover them, and let it heal. I had a guy come in one time in Blackwell, I won't ever forget it. He cut his finger off in a table saw accident. And he had lost like 4 fingers in that same damn table saw. And this was another one. Not the whole finger, just parts of the finger. It's like, why do you keep using that table saw? Where's the guard? I mean, how many times? 1, 2, 3, now 5 times. How many? If I hit you in the head with a stick, is it going to take you 5 times to know that? Oh, anyway, you know what I'm getting at. Ankylosing spondylitis, mostly young men, chronic low back pain. The SED rate is your key here. The SED rate is your key because the rheumatoid factor is going to be negative almost always. The other thing, though, is an HLA-B27. There's a high correlation here between that major histocompatibility antigen and ankylosing spondylitis. You can have, as it says here, you can have an HLA-B27 and not develop ankylosing spondylitis. It's not causative, it's prediction. So if you have a guy with a young guy with chronic low back pain, on x-ray there's no fracture or dislocation, subluxation, so on, you got a positive HLA, you get an HLA-B27, and I've only ordered maybe 10 of them in my lifetime, and it's positive. That will, prediction is that you have ankylosing spondylitis, and we're going to put you on a DMARD to help you out. Later in the disease, you get bambooing of the lumbar spine, but that's much later in the disease. Okay?
What exactly does that mean?
What?
Bambooing?
You know how a stalk of bamboo looks like?
Yeah.
You know, it has the joints, but it's all one thing.
Yeah.
That's what this is supposed to be showing.
Okay.
Okay, if you look at do a Google images for bambooing of the cervical spine. It also happens when there's a lot of spasm in the cervical spine, not from the disease like ankylosing spondylitis. That always involves just the pelvis and the lumbar spine. But if you have a lot of contractures of muscles in the neck, the spine, the cervical spine, instead of having its normal lordosis, it will be straight, and it looks like a stalk of bamboo. Okay. Temporal arteritis is another connective tissue disorder. This is an inflammatory process involving mostly medium-sized arteries. The superficial temporal is the one that you hear about. So superficial temporal arteritis, giant cell arteritis, that goes by several different names. And the reason this is such a problem, and it mostly occurs in old folks. If anybody over 70 or 80 comes in with scalp pain, visual disturbance on one side, very tender to this part right here, then temporal arteritis is your #1 on your differential. If you miss this diagnosis because of the inflammatory process involving the arteries, it can occlude the ophthalmic artery, and they can wind up with a unilateral blindness. That's why you never miss this. And you don't have to miss it, because when an older person comes in with headache, scalp pain, this type of thing, all you gotta do is get a SED rate. The SED rate will be uniformly high in temporal arteritis. The SED rate's your best thing here. Or you can get a CRP, but the SED rate's the easiest thing. Now, in calculating the SED rate, as you get older, the SED rate changes. And as you see here, you can take the age divided by 2, that's the normal SED rate for males. In women, you gotta add 10. Age plus 10 divided by 2 is the normal SED rate. So in me, my normal SED rate would be 30 millimeters an hour. For you, it'd be roughly 10. Okay? Biopsy is the definitive diagnosis. And by the way, on your board exams, you have to watch out when you're reading these questions because they have different things like, what's the initial diagnostic study? So the initial diagnostic study in a knee injury is a plain film. It's not an MRI. So you have to know what would you do first. The other thing that will catch you is what is the definitive diagnostic study? The definitive diagnostic study in a knee is an MRI. The initial study here is a SED rate. The definitive diagnostic study is biopsy. Anytime you look, if they say that if you see definitive, that means you're looking at the structure. Surgically, microscopically, you're looking at the structure. The definitive diagnostic procedure for colon cancer is colonoscopy with biopsy. Right? When you take the board exam, you just need to keep that in mind. This is what they see on biopsy here. Giant cells are the pathognomonic cell type for giant cell arteritis or temporal arteritis. And what these are is their syncytium. It's a syncytium where cells feed like a multinucleated giant cell. And you can see examples. There's one right there. You can see it within the normal, the inflamed artery here. Over here, the lumen of the artery is almost completely obstructed by the inflammatory process. These things, temporal arteritis responds exceptionally well to steroids in the office. So if I have a 70-year-old or 80-year-old coming in, headache, scalp pain, blurred vision in one eye, I'm going to do a couple of things. One is I'm going to get a SED rate, I'm going to get a CBC, probably get a CFP just to make sure, look at your liver and everything else. I'm going to start you on high-dose steroids there in the office, and I'm going to schedule you with an ophthalmologist. I'm not going to schedule you with a surgeon for a biopsy. Polymyalgia rheumatica is a SED rate. This is your biggie here, disorder. There are certain characteristic features of this. Pain and stiffness of the shoulder and pelvic girdle with other types of symptoms like, this is an acute process, with fever, malaise, and weight loss. What distinguishes this is stiffness, pain, fever. It does not occur in young people. And the hallmark sign here is when it usually occurs in women, they say that they have stiffness and weakness in trying to comb their hair. They can't, because it involves the shoulder and the pelvic girdle, they can't do this. Okay? steroids is an easy fix for it. Unfortunately, the differential diagnosis in an older person with these complaints is as long as your arm. If it responds to steroids, though, you've got it licked, and there's a high SID rate. And by high, I mean like 100 millimeters an hour, not blown out high, but anywhere from like 50 to 100 millimeters an hour. Scleroderma, if we look at scleroderma, there's a couple of things here. There are two forms of it to start with. There's a diffuse form that occurs in some people. Most of it is going to be this crest form. The crest form involves those different characteristics that I had on that previous slide. Raynaud's phenomenon is a vasculitis of the digits, the fingers and the toes that become, when exposed to cold temperatures, they contract so that the fingers become blue and very painful because their blood supply is decreased. They usually become ischemic over time, and most people with Crest syndrome will lose their fingers. As you see here, this poor woman has lost her fingers on this hand and most of them on this hand right here. There's another example of calcinosis cutis. So SCL70 is what you're looking for. Unfortunately, is it causative? Maybe so, but then it's only positive 60% of the time. The specificity is high, the sensitivity is low. RF and ANA really don't help you a whole lot. ANA is slightly more helpful, that you see here. This is the disorder, I may have mentioned this in anatomy, because it involves cross-linking of proteins, it essentially the skin becomes shiny and they lose the normal ridge lines, and it turns people to stone is the phrase. So I've known people with this, and it was just a tragedy. Young people with this, and it's a tragedy. Okay. Myositis, there are two forms of myositis. There's myositis without a rash and myositis with a rash. If it's with a rash, it's called dermatomyositis. The pathognomonic feature of myositis is weakness, proximal muscles of the pelvic girdle and shoulder, characterized and most pronounced when trying to walk upstairs. So if a person says they can't comb their hair, you're looking at polymyalgia. If they say they can't walk upstairs, you're looking at myositis. If they can't walk upstairs with a rash, you have dermatomyositis. A quick biopsy of that rash will give you the diagnosis. You see here that ANA is a nice predictor of this disease. One thing that if you suspect this, myositis is an inflammation of muscle. It's an autoantibody directed against muscle destruction. And one of the things that you're looking for is CK, creatine kinase, which is in muscle, primarily in muscle. So these people with myositis will typically have an elevated CK. Aldolase is another enzyme that's within muscle that helps break down a certain sugar. It's rather specific for muscle. So you want to make sure if you're trying to work up or rule in or out myositis or dermatomyositis, get a CK and an aldolase. CK is on a CMP, aldolase is not. You have to order it specifically. The issue here, even though this is rather an innocuous disease, by say innocuous, I mean you can control it pretty well, and you don't have to worry about a whole lot of downstream things like restrictive pericarditis. There is a problem with dermatomyositis though, in that 1 in 4 will have a malignancy, develop a malignancy somewhere, so you have to be vigilant about that. Antiphospholipid antibody syndrome, this is a bizarre thing. These are antibodies directed against cell membranes. Remember the phospholipid bilayer? This is an antibody directed against membranes. And the thing about these is, there are a couple of things about this. I've never seen a case of this. If a person has recurrent miscarriages, and one of the things here is that the cause of that is possible antiphospholipid antibody syndrome, recurrent fetal loss. So anytime, if you're an OBGYN, you have a woman who's had 3 miscarriages this year, you definitely ought to get antiphospholipid antibody, Tiger. There are other things that are associated with it, anticardiolipin and a lupus anticoagulant. These are antiphospholipids. The reason you would get these if you have somebody who's having frequent miscarriages or who is in a hypercoagulable state. If you have somebody with a DVT or a pulmonary embolism and you don't know why, these are 3 of the studies you're going to get, 3 of the many studies you're going to get to try to figure it out. Along with things like that produce hypercoagulable states, like protein S deficiency, protein C deficiency, factor V Leiden. I've mentioned these before, I believe. Okay. The other board type thing is that if you have antibodies to phospholipids, this is one of the few things that will be a false positive on an RPR. Lyme disease, Borrelia burgdorferi, is not endemic to Oklahoma. But because everybody travels, you have to consider it. There's no endemic case of Lyme disease in this state. There's people that argue that, but there's been so many studies that there's no endemic bug in this state. The problem with this disorder is there's a pathognomonic rash of Lyme disease is erythema migrans. Where it first entered your body, you develop this target-like lesion, this target-like rash. And then as you recover from this rash, a similar rash will appear over here. And then once that one starts healing up, 2 other lesions appear on another limb. It tends to migrate. That's why it's called erythema, the redness, migrans. That's pathognomonic for Lyme disease. And in addition to its significant problems with the heart and lungs and all sorts of viscera, it produces a polyarthritis that you need to consider. It's very easy though. All you got to do is get a Lyme titer. That'll tell you right there whether or not you have Lyme disease. I've ordered a lot of these and diagnosed Lyme disease quite a few times because people travel to other parts of the state. And it's endemic to, of course, the New England area where it was figured out. And then all across the top of the country, up around the Wisconsin, the Minnesota, Michigan area, and then down the West Coast. It just spares the central part of the southern part of the United States. Fibromyalgia is something you're going to run into a lot It's mostly, probably 99% of the time, a diagnosis with females, mostly perimenopausal age, maybe a little older. One of the speakers, I can't remember who talked about it, and I think it was maybe Scott Inowitz. He said this is something you're going to run into a lot, and he used to think it was BS, but now he feels that it's more of a specific disease, and it probably is. I don't doubt that. It's chronic, achy pain, probably associated with depression, arthralgias, and you can't find a reason for it. All of these tests right here will be negative. You order the universe and it will be negative. There are a couple of features about fibromyalgia. One is they have trigger points. They have little places of spasm in their backs, in their shoulders, in their cervical spine, and they're painful. And in making the diagnosis of fibromyalgia, you need to have trigger points. And the way you treat the trigger points is you stick a needle in them and inject the steroid with Marcaine, long-acting anesthetic, and that relaxes the joint. Relaxes the spasm. Okay? Gives them some relief. What you do never, ever treat fibromyalgia with an opioid or anything addictive. No matter how much they complain of pain, you will make an addict out of them 100% of the time. Maybe not 100%, but it's high. Okay? If there, and this is an important point here, if there's an objective finding, it's not fibromyalgia, other than trigger points. It's something else. When I was a student, before the word fibromyalgia was coined, this old farmer, this old doc out in western Kansas, he called this the falling hand syndrome. So these, and it was always women. 99.9% women. I don't know if that's correct. I just made that number up, but it seems like I've never seen fibromyalgia in a man. Their alcoholism or something else. It's not fibro. Anyway, the falling hand syndrome was, Miss Love, my hair seems to be falling out, but I had a nosebleed the other day, and my teeth are really sensitive, and I got this lump in my neck, and I also have chest pain and I can't breathe, and my stomach hurts all the time, and my periods are irregular, and my knee hurts, and their hand falls all the way to the floor with another disorder. And sure enough, now that I look back on it, that was fibromyalgia. It is a disease. I used to think it was just depression, empty nest syndrome. Get a job. But now I think it's a real disease. I didn't mean get a job because anyway. I think it's a real disease. So don't file some complaint on me about being sexist. Again, it's 99.9. It's the alcoholism in the guys. Okay, or gambling disorder or something else in the guys. Any questions? You want to argue about it? All right. Bonnie? All right. Here's a table here showing the predictability of all these things. It might help you. Certainly don't memorize this table. Look at it and see if that will help you sort of organize your study into these different tests. Here's an example. We got a case study here. We've got a 60-year-old guy with a 2-week history. He's got fever, cough, dyspnea. He's got a red rash on his face and his upper torso. He's got some changes on his chest x-ray. Muscle strength is a little off in his bilateral muscles. He's got a CK markedly elevated there. Positive anti-Joe. What's this guy have? He's got a rash, so it's dermatomyositis. He's 61 years old. What would you, so you just diagnosed dermatomyositis in this guy. Would you put him on steroids and send him out the door? What else would you be looking for? What? Malignancy. So in a 60-year-old guy, what malignancies would be? Does he smoke? Is one thing. So chest X-ray showed interstitial infiltrate, didn't show any coin lesion. So okay, lung cancer maybe out. What else would we look for?
Prostate.
Colonoscopy. Has he had his colonoscopy? By now he would have had 2. Were they both negative if they were screening colonoscopies? What else?
Prostate.
Prostate. Do a rectal exam on this guy. Do a hemocolt for the while he's in your office. Get a PSA. So those are, make sure his thyroid's smooth. Does he have any abdominal complaints? Worried about, pancreatic cancer. So don't just take this and you're done. So when you're talking about a focused exam, you're not focusing on his rash or his arthritis. You're having to think about, okay, on the differential with dermatomyositis, 1 in 4 of these people have a malignancy. You got to rule that out too. Okay. Any questions? So you're going to go meet your SP here in a little bit, and then those that are in my group tomorrow will be upstairs in the conference room. Just email me your write-up. You don't need to give me a hard. I'll print it off up there.